Hi, everyone. My name is Carissa Brewster. I am the writer for Whitman Partners, and we are doing our 40 Fast and Future Leaders of Surgical Services for 2023 Recognition Awards series. And today we welcome Jennifer Drudy. Welcome, Jennifer.
Hi, thank you.
And can you tell us your current title and the facility where you are right now?
I am the Director of Perioperative Services for Roper St. Francis Healthcare in Charleston, South Carolina. Moving into this position at my previous facility, it was a singular acute care facility. It was not a part of a system. And taking the leap to come here to South Carolina, my role is 4 hospitals and 2 surgery centers. So it was a big growth, and it's all surgical services, not just OR and anesthesia. And so I really had to learn how to build relationships with people that I had never met before. Because my previous role, I worked at that hospital for 13 years before I left. I knew every surgeon, pretty much every staff member, all of the leaders in other departments. It was a pretty easy transition in terms of that, versus here where I came in and I really didn't know anybody. And it was still kind of COVID times. And so meetings were not in person, everything was on a WebEx or a Zoom. And so it was really hard to build personal relationships that way. So I think I really had to learn how to adjust to developing those relationships, and getting buy-in from key stakeholders that didn't know anything about me. And so it really honed my skills in learning how to work with people that you had not encountered before and gain their trust and get them to buy in when you have to make a change or implement a new product or things of that nature. I I really feel that being visible and available is so important to making sure that you increase retention and engagement with your staff. When I first moved into my leadership role in the OR at my previous facility, I made sure we had a safety huddle every morning, and I was there for every safety huddle. I made it a point to be there and be visible, even though I didn't run it. I wanted the staff to be able to bring up any issues that they had. And I started out in that role rounding every morning after the safety huddle. I would go to every single room and ask every person, did they have everything they needed? Were there any issues that needed to be addressed? And staff really felt valued by that, because they were like, somebody's listening to what my issues are and trying actively to fix them. And so that really helped me build relationships with staff, and get buy-in when I needed to make change, because they knew that I would work with them when we had to make a change. And I think being available, staff want to know they're supported, and the way that they feel supported is when you're there to help them with any problems that come up. So I always tell people I have my phone on me 24/7. If you call me, I will answer, and I'll do my best to help you with any issues that you have. And then I think in terms of engagement, another portion of that becomes really communicating and working together with the staff when there's things that you need to change that come about, especially now that we've gone through COVID. There's a lot of policy change that came about with COVID, and working together where you bring up what the change needs to be and you ask for the staff's opinions and you use shared governance. That really helps build and maintain engagement with the staff, because they feel that their voice is being heard, which is really important to them. And I think sometimes, we may have to roll out change that you can't ask for their opinion, because it is a regulatory change or a policy change that really it has to be done the way it's written. And I think in that way, that's where communication plays a big role, because you need to explain to your staff the why. Most people, if they understand why you're doing something, even if they're not really in love with what that change might be, they're still willing to go down that road and give it a try, because you've told them why you're making that change and you've given them an opportunity to voice any concerns they have. So I think those are two really important things in terms of retention and engagement. I think it's really my drive to learn and pursue new things, and even like in uncharted territory. Certainly, if I didn't have that drive, I don't think I ever would have made the change to kind of pick up and move to a whole new state and take a job that really was a huge growth for me. And then I think I really thrive on learning and putting myself in new situations, which help me grow and support my departments because I'm willing to take chances when needed. So I would say negativity in the department really creates a challenging and unproductive work environment. If you just have even one or two, what I'll call like naysayers or negative people, even when things really are going smoothly, they just bring the morale of the whole department down. And then that significantly impacts their productivity because other staff members kind of get into this flow where they're like, oh, you're right, it that is so terrible when these things happen, and why do I even bother putting the effort in to have like a great smooth day when I just know something's going to go wrong. And so I really think that that impacts it significantly. And so it's really important when you have those people that are negative all the time, like I'll pull them aside and sit down with them and say, okay, talk to me about what the problem is. Help me help you fix it so that you don't have to come into work every day feeling that negative about what's going on here, and what can I do to support you? Because if you don't get that taken care of like pretty quickly, they're just going to bring the whole department down and you're just going to be struggling to dig yourself out of that hole. So I've seen a lot lately in terms of AI. There's a lot of different companies that are developing programs that use recording of what's going on in the ORs, right? So they'll put cameras and they'll use those cameras to track movements and record tasks that are happening. So we came in the room with the patient, we put them to sleep, we made incision, and some of them are even going so far as to try and figure out a way to get that to speak to the electronic medical record so that it can push through documentation items. So events like, okay, we came in the room, we closed, we left the room, and then using that to track metrics so that you can look at efficiencies and how can you become more efficient and how can you make your turnover times better and things of that nature. And I've actually had the ability to see two companies products and how they work, and they're pretty interesting if they come to fruition and push that out. So I think it would be really cool in terms of being able to track your metrics and look at areas for efficiency improvement. The one thing that I will say though is when I've heard staff that have seen these same products or surgeons, they're very concerned about being recorded in the room. Like they don't really want to go down that path. So I'll be interested to see how these companies roll that out and get people to feel more comfortable with the recording, because that's one of the things I could see might be a pain point for them in terms of getting this to be successful. I would say for me personally, block utilization, I probably live my whole life revolving around block utilization now in this role. It's so important because, surgeons want access to the OR, they need time to do their cases, and really taking what your block is and its utilization and optimizing that to be like the perfect amount just really helps with efficiency. It helps you to be able to build volume too. If you can really get that down to like the nitty gritty, you have the ability to add more cases or give more time to other physicians. And so I think that would be something I would be heavily interested in listening to a panel discussion, seeing what other people are doing, because I really, I've only been at two facilities where block utilization was something I really had to worry about, my previous facility and now here. Prior to that, I was a staff OR nurse and everyone understood block, but you weren't really responsible for how it was run or who got block or any of those other things. So really, that would be something I'd find super beneficial to see how other people throughout the country are managing that in their facilities.
That's cool. Um, would you have any ideas of yourself about like to share with your peers about block utilization based off of your experience?
So a couple of the things that I try to make sure to do, we run block and send out quarterly letters. So physicians always know where they're at. And then we have a policy at our facility about what we require to maintain block. So we require 75% utilization to keep the block that you currently have. And then 90% if you want to add. And then if you're below 75% for 2 consecutive quarters, then we look at adjusting. Do you really need the amount of block you have? How do we make that work? And then I think another important thing in turn for where I'm at right now is we really try not to have more than 80% of our overall available time in the OR blocked, because that really makes it difficult for you to be able to do add-on cases or emergent cases, because you're really filling your whole entire day with block. And then you're doing those cases at 7, 8, 9 o'clock at night. And nobody really wants to do something that's not super emergent late in the evening. So I think those are two things that we're focusing on that have helped. And then, any other tips and tricks would be great to learn in a panel discussion. Periop specifically, we really need to be cognizant about supplies and purchased services. So how do we get to a place where we're standardized and efficient with the supplies that we use, the service contracts that we have, and other things that revolve around running the peri-op departments, and really looking at that and saying what's truly needed and what could we maybe not have in place. We're even looking at here at my facility, our robotics program, and can we get every physician to agree to use the exact same number of robot arms and instruments and supplies on all of their cases and help drive supply costs down. Thankfully, our physician groups are pretty great, and they're invested in making sure that we're fiscally responsible. So that's one really great thing with working with them here, because they're also invested in that. And then I think the other thing for peri-op side is figuring out how to maximize our outpatient procedures. So can we look at some procedures that, in the past may have required a 23-hour OBS, or at least, a 1-day stay after surgery, and move that to, I can go home. So we've looked at options of, hospital at home. So could we potentially have the staff that work at hospital at home check up on these post-op patients after they're discharged the next day, and that prevents them from having to stay overnight, or looking at how to do procedures in a way that makes them more viable to go home same day, because that overall helps drive down cost. And then I think in terms of just the acute care in general for like the facility, really looking at length of stay, readmission rates, and then having a weekly or monthly operating meeting where you're tracking that, because looking at that on a regular basis helps you identify issues sooner. If you're looking at your volumes and your readmission rates and your length of stay on a weekly basis, and you can immediately address that and start pivoting, that's really helpful, versus getting to the end of the year and you're not really meeting your metrics, or maybe quarterly or even every 6 months, and you're digging yourself out of a bigger hole, versus looking at that kind of on a regular, more immediate basis and addressing issues as they come up. Say it's a toss up between surgeons and seasoned direct reports. And I think the reasoning behind that for me is it's very similar. Surgeons, they spend years training to be in their field, and while they're training, they use particular products and they do certain things during that training period. And then once they come out of their residency or their fellowship, they want to continue using what's familiar to them. And you really, if say you're a Depew facility for total joints and they used Stryker throughout their whole fellowship and residency, and you really have to talk to them about, well, I'm just not sure. We have to look at pricing and things of that nature. It can be very difficult to get them to make that change. And so you really have to use your data, your information, have conversations with them, get their feedback, have open dialogue and communication about why certain needs need to change, or we might need to pursue a different product. And so it's really about communication and having that information. Data is such a strong tool. If you can go to somebody with, like, especially in situations where we're looking to change products, the financials, like if I can show, if you're willing to just trial this and see if it's usable, and we could have, like, let's just say a $50,000 savings for the year, that's a huge impact. And most people will then be like, okay, let me trial it. I'm willing to give it a try and see what'll happen. And if I really hate it, then can we work something out for me? And I think that's also important, is being willing to have the give and take with them, because if not, you're just going to lose any ground that you gained by your communication. And then it's really the same thing with seasoned direct reports. So many times, and I'm sure every perioperative leader will say they heard this sentence, like, we've done it that way for years and it's always worked, and why do we have to change, right? And sometimes we're changing because best practice changes. We learn new things and we find new ways to treat people that are just better than what we did in the past for the patient, and we want to be patient advocates. And so you really have to use the same tools. You want to show the staff the data and say, look, it's clinically proven to be better, and that's why we need to make this change, and give them the background and talk about the why. And then you know for them to get the buy-in, I really like to say, give me your ideas about how we can make this change, because it doesn't need to be the Jen Drudy show, is what I'll say to staff. Like, it doesn't be or the highway. To me, it doesn't matter how we make the change, as long as we get to the end result. And it's important that you have a voice and give feedback, because you're the one that's going to have to be living that change every day clinically in the rooms. And if it doesn't work for you clinically, then we're not going to be successful in the change. And so I really think that communication, the data sharing, and the give and take of how you roll that out are so important to get those stakeholders to be on your side.
Well, thanks for joining me today, Jennifer.